Before we get started, I have a quick favor. I've been self-funding the Finding Genius podcast for 5 years now. I've done over 3,000 episodes. And as you can see on YouTube, we're up over 1 million views on the channel, which is fantastic. The next thing I really want to push on is to get up to 10,000 subscribers. Because once we do, we'll be able to put a donate button and we'll be able to solicit donations to help keep the podcast running and to also get the Finding Genius Foundation moving along. We have a big project studying anxiety, depression, and PTSD and working on a product to help people overcome these problems because I've seen them explode recently after the last 2 years of the whole virus situation. So if you would, please subscribe to the podcast. That would help us tremendously. Give us a thumbs up and check in the description for Buy Me a Coffee. It's about $5. If you could buy me a coffee, I'd really appreciate it. It would help keep the channel going, and I love coffee. Thank you.
Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. My guest today is Dr. Judson Brandeis. He's a urologist and a sexual medicine expert. So we're going to talk about the 21st century man, advice from 50 top doctors and men's health experts to help you feel great, look good, and have better sex. His book. So welcome, Judson. Thanks for coming.
Oh, it's my pleasure. Thanks for having me on.
Yeah, tell me a bit about your background. What got you into this, I guess, uncommon area of study?
Oh, gosh, I had a kind of a surreptitious way of ending up where I ended up. So I was a history major at Brown University, and after graduating, I went and worked at American Red Cross for a guy named Harold T. Merriman, who was the first person to figure out how to freeze blood. And we were actually figuring out how to freeze kidneys for transplantation. And I got really interested in kidney transplants. I went off to Vanderbilt for medical school. And then during medical school, I decided to take a year off and do a year of Howard Hughes Medical Institute sponsored research at Harvard Medical School at the lab that did the first living-related kidney transplant. And so then I went back, finished up medical school, and went off to UCLA, did 2 years of surgical training, and then 4 years of urology training, where doing kidney transplants was part of what I was doing, but I became really interested in prostate cancer and the emerging technologies of surgical robotics. And so I helped pioneer surgical robotics. We had the second Da Vinci surgical robot in the country, and went into private practice in Northern California and helped pioneer Kidney Stone Center and MRI-guided prostate biopsies. But about 6 or 7 years ago, I became really interested in regenerative treatments for men for sexual function. So things like low-intensity shockwave therapy, high-intensity focused electromagnetic waves, stem cells, PRP. And now I have a practice in Northern California that focuses on men's health, exclusively men's health, help men restore their sexual function, their hormonal function, and physical optimization. And the 21st century man was kind of an outgrowth of learning about all the different technologies and all the things that you can do to help men live a better, more productive, happier life.
So what's, I don't know, what are things that are common to many men that cause them sexual dysfunction in their life?
Well, I'd say 90% of sexual dysfunction is vasculogenic, meaning that the blood vessels to the penis start to get clogged. And that can become from aging, from smoking, from drinking, from sedentary lifestyle, from not eating the right foods, from genetics. And so, we're all fighting an uphill battle as we age, especially after we get to 50, to maintain not just lifespan, but health span, and even what we call sex span, the ability to be sexually active as you age.
So what are the common things that happen to men? What do they start to experience as they get older that tells them they're starting to have some dysfunction?
Well, sexually, the first thing that happens is you lose morning erections or nighttime erections. And then after about 10 years of that, you begin to develop erectile dysfunction. So the ability to maintain an erection, when you want to maintain an erection, you begin to lose. And then 10 years after that, you begin to get cardiovascular disease, heart attacks, strokes, those kind of things. And so it's really a continuum. And the important thing is to be aware of your loss of function and what that might mean. So, a lot of guys lose morning erections, don't really think much about it. Then they start to have erectile dysfunction and they just order some blue pills from, an online doctor. And then 10 years later, they have a heart attack. The erectile dysfunction is kind of the canary in the coal mine for men's health. It means that your circulation isn't as good as it should be. And you should begin to generate some awareness that you need to take better care of yourself.
Yeah, but again, what does this mean? So what is the average man supposed to get multiple erections a day or in the night? Or, what is a normal circumstance and what is a non-normal one that you run into?
Yeah, well, I mean, normal is kind of all over the place. I like to think more of
Like
aspirational.
what if you only get an erection when you're about to have sex, with your partner? Otherwise, you never get one. Is that a real bad sign, or like what should men expect and look out for early on?
Well, I think that would be unusual, right? So you get nighttime erections so that your penis is ready to have daytime erections. So yeah, it would be rare to just have a guy who only gets erections when he needs to get erections. So, typically you'll get 30 to 60 minutes of erections every night when you're sleeping. And that brings oxygenated blood and nutrients into the penis. It stretches the connective tissue of the penis and prepares the penis so that when there is opportunity to have penetrative intercourse, that you're ready. Does that make sense?
How are you supposed to know, though, if you're sleeping? So how can anyone know that? Unless you're
Well,
in
a
a
lot of
lab
guys,
setting.
yeah, I mean, a lot of guys will wake up in the morning with an erection. The other thing is that there is a device called the FermTech. It's a ring that you can put around the penis, and that will help you figure out if you're getting erection.
Yeah, but won't that choke off blood and stop the ability of the penis to become erect in the beginning or in the first place?
No, because the blood flow that goes into the penis goes through something called the deep cavernosal artery. And you have one deep cavernosal artery in each erectile body. And so what a ring would do would be to prevent blood from returning back to the body. That's how you actually get a rigid erection. So the blood will continue to pump into the penis, but the drainage of blood out of the penis is impeded. But as the pressure of blood coming through the deep cavernosal artery decreases, then the erection will start to go away.
So what can men do at these various stages of dysfunction?
Yeah. Well, I mean, there are 10 things that I recommend men do that
Mm.
will improve their health in general, and certainly will also improve erectile function. And that is, don't drink alcohol, don't smoke, don't do drugs, don't eat too much, exercise every day, stretch every day, meditate every day, get enough sleep, and be nice to other people.
Okay, so what happens when you get people that are having dysfunction and you tell them this, and then what do they say? Yeah, that sounds great, or like what specific protocols do you suggest to people to
Yeah.
help them?
Well, when I see my patients in the office, especially when I see new patients, we'll get a full set of labs. We'll take a full history. We'll do a body composition scan. Because what I find is that men really respond to numbers, right? So if a guy's testosterone is 250 and the testosterone that he should be at is 600 or 700, and he's tired and he's got low libido and less motivated, then we talk about testosterone replacement. If a guy has not enough muscle and too much fat, then we talk about, what that really means. And we talk about calorie restricted diet, and we talk about exercise and how to build muscle and where to build muscle. So, everyone's an individual, but everyone to a certain extent needs the same sort of things. And that's the beauty of the 21st Century Man book, is it's 101 chapters that focus on really every aspect of men's health, from physical health to emotional health to relationship health to aesthetic health to addictions, all sorts of things. And it's written specifically for men in a voice that men will relate to.
Okay, what about testosterone replacement therapy? What are some of the nuances there? Should people do creams or injections or patches? What have you seen?
Yeah, that also is a very complicated question. But in general, creams and patches and anything that's transdermal, I mean, that has to go through the skin, will only get you to a level of around 500. And quote, normal testosterone for men is between, say, 300 and 900. But I find that the best physical performance really happens from around 900 to 12 or 1300. And the only way to get to those levels are either injection therapy or pellets. And so the less expensive way to get it is through injection of testosterone, meaning you have to inject yourself either once or twice a week with testosterone. And the other way to do it are to place little pellets So I'm a BioT testosterone provider. We make a tiny little puncture. We place these pellets, which look like little grains of rice, under the skin. And those pellets will last for about 4 to 6 months. And that gives you a nice, even level of testosterone.
Okay, so what should again, what is injectable a safe procedure for people, or pellets better? What about creams, topical creams you rub on?
Yeah, topical creams, like I said, they're not going to give you the levels that men need, especially as they age.
I've
Kind of
heard with those, you put them on the scrotum itself, the underside is supposed to be more efficacious than just on your stomach or arm, let's say.
slightly more, but think about it this way. When you jump into a swimming pool, do you become waterlogged? No, of
No.
course not, right? So water is H2O. It's a very small molecule. Testosterone is a 27 carbon chain, right? Compared to water, it's a very, very big molecule. And so it's very hard to get a molecule that size to go through the skin and into the bloodstream where it needs to be. And so it doesn't matter if you put tons of testosterone cream on you. It's very hard to get levels that will make really a big difference. I use creams and those kind of things for, say, men with prostate cancer, where you want to boost their testosterone a little bit, but you don't want to get too high. But for an average 50, 60, 70-year-old that has a low testosterone that wants to improve their physical performance, sexual performance, etc., shots or pellets are a much, much better way to go.
Okay, so what are the physiological effects when someone does this? Like, how do they tend to feel? How long does it take?
Yeah. So, with shots, they can feel better almost overnight. And it improves their motivation, their drive, their sex drive, their ability to build muscle, their ability to burn fat, sleep, mood. It really, that expression, everything's better with bacon.
Right.
Everything's better with testosterone.
Well, not necessarily. I mean, what about cardiovascular inputs?
Yeah, actually,
I've heard that it can raise your risk of, like, I don't know what the circumstance would be, but stroke or heart attack.
yeah. So actually, there was a recent study that came out called the Traverse study, which was a massive study that showed that testosterone replacement actually was heart healthy and actually did not have any negative effects on cardiovascular fitness. Didn't increase heart attacks, didn't increase strokes, and they're actually removing the warning label on testosterone products based on the Traverse study.
Well, that's good.
Yeah, so it's actually very good for heart. It's actually very good for diabetes as well. So type 2
What about lumps
diabetics.
and bumps and stuff? I've done injectable testosterone. I get lumps, and I had to get acupuncture to get them down. And the people that testosterone places like, oh, it's just normal. And I asked about different carrier oils, and I don't know, didn't really know anything. They're just there to inject you. So what have you seen that works well or doesn't work in terms of TRT?
Yeah, so honestly, injection therapy is great, and to be honest, I haven't seen any of my patients complain of lumps or bumps. But I have a shockwave therapy device in my office that, if there's any little lumps or bumps, we could easily kind of iron that out. If you rotate the injection site, left, right, and and testosterone is best injected intramuscular. So if you inject into your deltoids, into your quads, into your glutes, and rotate that around, not every single time in the same place, then you're much less likely to generate scar tissue. There are also subcutaneous injection systems like Xiasted that give levels that are around 700, 750. So if you're having difficulty injecting intramuscular, you might want to consider something like Xiasted.
Oh, has anyone ever looked into the carrier oils? Because I know one's cottonseed. There's like testosterone, enanthate, cyprinate, etc. There are forms that you recommend or don't recommend, or again, carrier oils that can be changed that would make it more efficacious or easy for somebody, or less of a problem.
Yeah, that's a really good question. I mostly use testosterone cypionate, and although some patients specifically request enanthate for I don't know what reason, and honestly, I don't have an expertise in the different carrier oils. But to be honest,
what are bodybuilders doing? From what I understand, they're using much, much, much more than a normal person would.
I actually have a really good ebook on performance enhancing drugs, and you can basically think of it as 3 categories. So a lot of those guys will use a testosterone base, right? So they'll inject high doses of testosterone, and then beyond the testosterone base, they'll use what are called dihydrotestosterone. So testosterone is converted by something called 5-alpha reductase into dihydrotestosterone, or DHT. And DHT has a higher binding affinity to the testosterone receptor, meaning it sticks to the testosterone receptor 3 to 4 times more intensely than regular testosterone. And DHT is what causes male pattern hair loss and also growth of the prostate. But also it has a much greater effect on muscle. And by altering the chemical structure of DHT, you can get more intense muscle building effects, more, what bodybuilders do when they bulk or they shred, or because these are all steroid hormones. And so there are a number of different corticosteroids. So there's glucocorticoids, there's mineral corticoids. So mineral corticoids, without getting too deep into physiology, are things that affect your kidney to affect your fluid levels. And so I think part of the reason that all these things got tweaked,
like diuretics.
Part of the reason they got tweaked was one, because of the slightly different effects, but also when bodybuilders and athletes were being tested for these different hormones, they would chemically alter them to avoid being discovered. And then they found different purposes and different effects of all these different hormones. So then there's DHT, and then there's another category called the 19-NORs, which is another kind of tweak of that DHT molecule that helps guys bulk and have more effects. So the bodybuilders that you see, competing, they're not just doing testosterone, they're doing DHT derivatives like DECA, Tren, or Winstrol. But those are really, really dangerous drugs or hormones, especially when you're doing it and you don't really know what you're doing. So I've seen guys in their late 20s that come in to see me that can no longer get erections, can no longer have babies because these testosterone has an effect on fertility, right? If you're taking high levels of testosterone and you're in your 20s, you're going to be sterile.
You're just pushing it too far, I guess, huh?
Exactly. Well, you're shutting off what we call the hypothalamic pituitary testicular axis, right? So the hypothalamus is in your brain and it reads how much testosterone you have. And then it sends a message to the pituitary, and the pituitary sends out two messages: LH, which tells your testicle to make testosterone, and FSH, which tells your testicle to make sperm. But if you're taking testosterone from the outside, the hypothalamus says, oh, well, we got enough, so let's shut the engines down because we don't need to make any more. So not only do you not make testosterone, but you also don't make sperm. And if you do that for long enough, then you can lose the ability to make sperm, and you can actually lose the ability to make testosterone.
So what happens to people that just take do injections only, therapeutic instead of bodybuilders? Does any of that stuff happen, or is it not enough to do that?
Yeah. I mean, if you do it for long enough. So I put my patients on a medication called Clomid or clomiphene, which blocks the negative feedback loop. And so those patients continue to get production of testosterone from the testicles.
What does it stop the production of estrogen, or what does it do? Is it like diindolylmethane, or like, what do you mean?
So DIM, it helps reduce the conversion of testosterone to estrogen, but I use a medication called anastrozole. Anastrozole is much more effective in blocking the conversion of testosterone to estrogen, right? So we think like testosterone and estrogen are radically different molecules. Men are from Mars and women are from Venus, right? But the difference between testosterone and estrogen is a single hydrogen atom. So the smallest unit of matter is the difference between men and women. And so it's very easy for your body to convert testosterone into estrogen. So when you're getting testosterone shots and you're getting levels of 1,000 or 1,200, it's important to get your patients on something like anastrozole or DIM, but DIM is much, much less effective than anastrozole in order to get the estrogen levels from being too high. Because like I had a patient a couple of months ago, he came to see me as a second opinion because the doctor that he was seeing didn't really know much about testosterone other than just tell him to take shots. And he was like, yeah, man, every time I watch the Niner game and the Niners score a touchdown, I start bawling my eyes out. And so that's what happens when your estrogen levels are too high, is that you get overly emotional, you get some breast tenderness, breast growth. It actually has negative effects on libido. And so testosterone replacement isn't just about sticking a needle into your muscle and injecting testosterone. You have to maintain and watch levels. You have to watch your estrogen levels, and you have to make sure that your testicular function, your fertility is okay.
So what kind of blood work will you do on someone that's having, erectile dysfunction? And what will you look for?
Yeah. So, I have a big panel of labs that I draw when someone comes in initially for erectile dysfunction, looking at liver function, kidney function, thyroid function, B12, testosterone, even cholesterol numbers, right? Because if you have high cholesterol, that's going to clog your arteries and that's going to lead to erectile dysfunction. So really, erectile function is a manifestation of your overall physical health. And so I talk to patients about the technologies that I can use to help treat their erectile function, like shockwave therapy and supplements and medications and HIFM and PRP and stem cells. But at the end of the day, if you're not taking care of yourself, if you're not doing cardiovascular exercise, if you're not watching your weight, if you're not watching what you eat, if you don't drink too much, if you don't smoke, then anything that I do in the office isn't going to work long term. So really, I'm looking to turn someone's life around and improve their overall physical health and fitness. At the same time, I'm looking to improve the blood flow to the penis.
Right, but what are some common biomarkers that would tell someone, whether they got them through you or their own doctor, that something's going on, they should pay attention to this? Do you see sex binding, globulin hormone high or low? Like what do you see?
Yeah, I mean,
Free testosterone
SHBG,
low?
certainly testosterone has effects on almost all physical functions of men. But testosterone is actually not directly involved in erectile function. Right. Erectile function is really a function of circulation of blood flow. And so that's more directly related to your overall physical fitness. And so when someone comes in, I have an ultrasound and I'll actually do ultrasounds of their deep cavernosal arteries to look at whether their arteries are narrow or the walls of the arteries are thickened or whether their arteries look relatively normal. So I think that really is the best way for me to assess with a single test what someone's erectile function is going to be, is to actually look at the blood vessels in the penis and assess what those blood vessels look like.
Does that correlate with the rest of the circulatory system, with heart?
Absolutely.
Or can you look at the heart and correlate that with the penis, or no?
Both. So there's a test called the heart calcium score.
Yeah, the CAC.
I had a patient the other day, and he didn't respond to the shockwave therapy like I thought he would. And I said, dude, you need to go and get a heart calcium score right away. And so he talked to his primary care, and his primary care said, no, I don't think you need it. I said, so he came back to me and I said, you need it. It only costs $250. I'm going to write you a requisition. Go get it. His levels came back at 1100 and he's going to have heart surgery next week.
What does that mean? What do you have? High calcium? What are they doing?
Means your blood vessels are clogged. And if your blood vessels are clogged, so a quarter of men, their first sign of heart disease is sudden death.
Okay.
So my daughter, this happened to her 2 days ago. She works at the Orange Theory, as a front desk. And she told me there was a 56-year-old police officer, a little bit overweight, did a class. Right after class, slumped over, fell down, massive heart attack. They needed to defibrillate the guy. And fortunately, he made it, right? But that's his first sign of heart disease. Was after Orange Theory. He did the full class, seemed to do okay, came out, slumped over. And if it wasn't for my daughter calling 911 and the coach doing heart compressions, the guy would be dead.
Yeah.
Never had a warning.
Crazy.
Never had a warning sign whatsoever. So here, this guy, he's been working for 30, 35 years, trying to support a family, et cetera, et cetera. And then he dies at 56 because, he never didn't go to the doctor, or the doctor didn't know the right tests, or he didn't heed the warning signs, right? I'm sure that guy's had erectile dysfunction.
So is it a good canary in the coal mine for heart health?
Absolutely. Absolutely.
Okay. So what is some of the most important testing that you'll do with people, for instance?
So I do a test in the office that's super valuable called the VO2 max. So VO2 max is a measure of fitness, really, but you basically ride an exercise bike or get on a treadmill and go to exhaustion, where you get to anaerobic, right? And your ability to push yourself into anaerobic is basically your VO2 max, and that has a high correlation with your overall cardiovascular fitness.
Okay, like what? What is the range of VO2 max? What's a good range, a bad range? What does this tell you?
Okay, so think about it this way. You're walking down the street. You use 2 liters of oxygen a minute. And then you start jogging. You use 3 liters of oxygen a minute. Then you start running. You use 4 liters of oxygen a minute. Then a bear jumps out from behind a tree and starts chasing you. So you start sprinting. You use 5 liters of oxygen a minute. And then the whole bear family starts chasing after you, and you use 5.2 liters of oxygen a minute. but you can't get any more, right? That's your VO2 max, right? Because glucose is the fuel that we burn in our body. And when you break down glucose, you add oxygen to glucose, and that breaks it up into carbon dioxide, which we breathe out, and water, and it releases energy. And that energy is in the form of ATP, right? And so there's a point where you can't bring in enough oxygen to properly oxygenate the breakdown of glucose and to liberate energy. And that's your VO2 max. And so the better athletes in the world, like Jonas Vingegaard, the cyclist, has one of the highest VO2 maxes ever measured at 97, right, is going to be able to extract oxygen and use glucose to a much greater degree than someone like you or I. Does that make sense?
Okay, so how can you tell if what's the standard for a normal person? Is
Let's
their
see.
VO2
So
max lower than they're in trouble, or what?
yeah, I mean, my VO2 max was 45 when I tested myself, and I'm 57. So that's, top maybe 2% for someone who's 57. My son, he's a cross-country runner. He's 18 years old. His was 70. The average for a man in his 40s, I think, is about 35. And for women, it's a little bit lower than.
Yeah, geez. Huh.
The thing is, you could do a stress test, right? You go to the cardiologist, they put you on the stress test, but the stress test really tells you, like, either you're going to have a heart attack or you have blood vessels that give you ischemia or areas of the heart that aren't getting properly perfused, or you're not. Whereas a heart calcium score will give you a score of, say, 0 to 1,000, and a VO2 max will give you a measure of cardiovascular fitness. So one is an imaging test and the other is a functional test. Whereas things like stress tests are going to either say you're at risk for a heart attack, or you're not at risk for a heart attack.
Right. So what are some of the therapies that you've developed or use to help people with dysfunction? Like, how do some of the top ones work?
Yeah. So one of the most popular ones and one of the best ones is called low intensity shockwave therapy. And what that is pulsed, you can think of them as sound waves or energy waves that go into the penis. And what that does is it tricks the penis into thinking that there's an injury, even that there's no injury. And what that does is it generates an injury response. And that injury response creates what's called neovascularization, or the growth of new blood vessels. So what you're looking to do is to increase new blood vessels. We also add what we call PRP, or platelet-rich plasma. So the platelets in your body contain growth factors in addition to clotting factors. And so we can draw blood, spin the blood down, isolate the platelets, and re-inject the platelets back into the penis, almost like adding fertilizer to a growing plant. And so that improves the vascularization. Now, the other thing you want to do is to improve the signal that your body uses to generate blood flow. And so there's something called nitric oxide. It's a naturally occurring molecule that is released by nerves. And when those nerves release nitric oxide, it generates something called cyclic GMP. And cyclic GMP creates a cascade of events that opens up blood vessels. And so as we age, the amount of nitric oxide that we produce reduces. And so that's one of the reasons we get higher blood pressure, less blood flow to the brain, less blood flow to the muscles, and so